Have you ever noticed how so much of medical training feels like you're just memorizing a static map?
Oh, absolutely. Yeah.
And then, you get into the clinic and you discover the territory is actually moving.
Right. It's not static at all.
No, you learn the pathways, the textbook presentations, those nice, neat little algorithms. But then you step into the world of gynecology,
Yeah.
and suddenly you realize you are dealing with this incredibly dynamic, constantly fluctuating chemical feedback loop.
Yeah, which is terrifying for a lot of trainees.
Completely. So welcome to today's deep dive. We are speaking directly to you, the GP trainee, the
Yeah.
one who's, staring down the barrel of the AKT, the applied knowledge test.
It's a beast of an exam.
It really is. You have this absolute mountain of curriculum to internalize. And look, we know that just staring at flashcards all night isn't going to build the clinical intuition you actually need to pass.
No, it won't. I mean, textbooks are excellent for giving you the ingredients, right?
Yeah.
But passing the AKT requires you to know how to actually bake the cake. The examiners, they aren't just looking for your ability to regurgitate a list of symptoms. They want to see if you understand the clinical matrix. Like, can you identify the critical pivot points in a patient's history?
Yeah, those little forks in the road.
Exactly.
Hmm.
Do you know the exact next best step in a really complex management pathway? And crucially, can you distinguish between two conditions that look virtually identical on paper, but, require completely different interventions in the real world of primary care?
Which is exactly our mission today.
Yeah.
Okay, let's unpack this. We are taking a massive stack of gynecology revision notes, guidelines, and clinical sources, and we are going to extract the underlying logic.
Good. Yeah.
Because instead of just memorizing what the treatments are, we really need to figure out why they work. I mean, I want to start by looking at the baseline.
The baseline is crucial, yeah.
Right, because before we can start fixing abnormal bleeding or navigating the heartbreak of fertility struggles, we have to understand the fundamental rhythm of the female reproductive system.
Okay.
The sources emphasize heavily that you need to know what happens when the system fails to start in the first place or unexpectedly shuts down.
Yeah, so the menstrual baseline is basically where your whole diagnostic algorithm begins.
Right.
The timing of menarche, the very first period that sets the stage, and the physiological window we consider normal is actually remarkably wide.
It's what, 8 to 15?
Exactly, yeah, anywhere between 8 and 15 years of age, with the average hovering around 13. But when a patient falls outside of that window, well, your clinical radar needs to shift immediately.
Okay, so if a patient presents with menarche before the age of 8, we are in the territory of precocious puberty.
Yes.
Now, my instinct as a trainee would probably be to assume, it's just early physiological development, right? Maybe it's genetically linked if her mother started early. But the sources are very clear that you absolutely cannot make that assumption in the exam.
You cannot. Do not fall for that trap.
Really?
Yeah, I mean, while idiopathic precocious puberty does happen, the AKT requires you to rule out the dangerous underlying pathology first. You must be thinking about central nervous system abnormalities.
Like tumors.
Exactly. Is there a CNS tumor altering the hormonal signals coming from the hypothalamus? You also need to consider endocrine disruptions, specifically congenital adrenal hyperplasia.
Oh, right, CAH.
Yeah, where an enzyme deficiency causes the adrenal glands to just overproduce androgens.
Okay, so early bleeding requires hunting for a major systemic trigger. But what about the other end of the spectrum?
The delays.
Yeah. Picture this. A 13-year-old girl is brought into your clinic by her parents. They are incredibly anxious because, all her friends have started their periods and she hasn't.
Classic GP presentation.
Right. So what is the immediate action plan? Because my first thought is, oh God, do I need to run a full blood panel right this second? Do I refer her to an endocrinologist today?
See, the key to that consultation and the key to getting the exam question right lies entirely in a physical assessment. That's what dictates your timeline.
Okay.
You are looking for a classic exam differentiator, which is primary amenorrhea. But primary amenorrhea has two very distinct, strict definitions, and it's all based on the presence or absence of secondary sexual characteristics.
Meaning breast development and pubic hair.
Precisely. If that 13-year-old girl sitting in your clinic has absolutely no signs of pubertal development, so no breast budding, no pubic hair, she meets the definition for primary amenorrhea right now at age 13.
Oh, wow. At 13.
Yes, and that requires immediate investigation.
But what if she does have breast development? How does that change our approach?
It buys you time. It buys you 2 full years.
2 years.
Yeah. If she has normal pubertal development, the diagnosis of primary amenorrhea isn't actually made until she reaches the age of 15 without a period.
That's a huge difference.
Exactly. In that scenario, you can just reassure the parents, calm everyone down, and adopt a watchful waiting approach.
I mean, that distinction is massive. It completely dictates whether you are drawing blood from a terrified teenager or sending her home with reassurance.
It really does.
Let's say she hits the criteria requiring investigation, though. The notes suggest we are looking for chromosomal issues like Turner syndrome,
Yeah.
where a female is missing an X chromosome, or significant endocrine failures.
Yeah, when you cross that diagnostic threshold, the initial investigations you're expected to initiate in primary care, they're quite comprehensive. You need to assess the entire hypothalamic pituitary ovarian axis.
So, brain to ovaries.
Exactly. That means ordering FSH and LH to see what the brain is doing, prolactin and testosterone to check for specific hormonal disruptors, and of course, thyroid function tests.
Right, the TFTs.
Always. The thyroid is basically the metabolic pacemaker of the body, and if it's malfunctioning, the reproductive system often just stalls completely. Ultimately, a confirmed case of primary amenorrhea will require an endocrine or gynecological referral.
Okay, let's look at the flip side of this coin, secondary amenorrhea. This is a woman who has had her periods, the system was up and running fine, and then it just, well, stops. The criteria here are highly specific, right? It's an absence of periods for 3 or more consecutive cycles if she usually has a regular rhythm.
Or 6 months or longer if she has always been irregular. Yeah.
Okay.
The differential diagnosis for secondary amenorrhea is just vast because the female reproductive axis is exquisitely sensitive to both internal chemistry and the external environment.
Right.
But before you start chasing complex endocrine disorders, you have to rule out the most obvious fundamental cause.
I'm going to guess pregnancy.
Always.
Yes.
Always pregnancy. It is the single most common cause of secondary amenorrhea, and you would be amazed how often it gets missed because a clinician assumed rather than actually tested.
Wow, yeah.
Once you have a negative pregnancy test in hand, then you move down the hierarchy of probability. Would consider if she is transitioning into menopause or if, this is just a side effect of a contraceptive she is taking.
Yeah, the sources outline a fascinating category of causes that are essentially the body hitting the emergency brake. Hypothalamic amenorrhea caused by extreme stress, excessive exercise, or eating disorders like anorexia.
Yeah, to understand why that happens, you really have to look at the evolutionary biology of the body.
Okay.
The hypothalamus acts as a central sensor for the body's resources. If a woman is running ultramarathons, or severely restricting her caloric intake, or is under immense psychological trauma, the hypothalamus registers a state of extreme scarcity.
Like a famine.
Exactly. It decides, quite logically, that this is a terrible environment in which to sustain a pregnancy.
So it just stops releasing gonadotropin-releasing hormone.
Exactly. The pulsatile release of GnRH just shuts down. And without that signal, the pituitary gland stops releasing LH and FSH, and the ovaries basically go dormant.
Fascinating.
Yeah. On a blood test, you will see low LH and low FSH. It isn't a disease in the traditional sense. It is a profound protective mechanism.
And the AKT is notorious for testing medication side effects that disrupt this system, aren't they?
Oh, absolutely.
The notes specifically flag tamoxifen, which makes sense as it alters estrogen receptors, but they also mention autoimmune hepatitis as a cause of secondary amenorrhea. I can easily see an exam question describing a patient with elevated anti-smooth muscle antibodies whose periods have stopped, and they fully expect you to make that connection.
They love combining specialties like that in the questions.
Okay, let's move from a system that has stalled to a system in overdrive. This is probably the most common presentation a GP trainee will see. Excessive painful bleeding, menorrhagia, or heavy menstrual bleeding.
It is a massive, massive part of general practice.
Yeah.
And the definition of menorrhagia is deliberately subjective. It is defined as excessive menstrual blood loss that interferes with a woman's physical, emotional, social, and material quality of life.
So you aren't asking her to measure the exact milliliter volume of blood?
No, absolutely not.
Yeah.
You are asking, how many times she has to change her sanitary products during the night, or if she's bleeding through her clothes at work. That's the clinical reality.
The required investigations here make a lot of physiological sense. A full blood count to check for iron deficiency anemia, because, if she is losing that much volume, her ferritin stores are likely depleted.
Yes.
A transvaginal ultrasound to look for structural issues like fibroids or polyps. And then, once again, thyroid function tests. We saw TFTs in amenorrhea, and now we see them again in heavy bleeding.
Because the thyroid acts as a master regulator. Hypothyroidism, an underactive thyroid, is a classic and frequently missed culprit for heavy menstrual bleeding.
Really? Just an underactive thyroid?
Yeah, it disrupts the coagulation pathways and it alters the metabolism of circulating hormones, which leads to this thickened, really unstable endometrial lining that sheds heavily.
Wow. The sources list several other causes for heavy bleeding, too. Anovulatory cycles are a big one, especially at the extremes of reproductive life, like right after menarche or during the perimenopause. Then you have endometriosis, which we will explore deeply in a moment. But the notes say to specifically suspect endometriosis if the heavy bleeding is accompanied by severe dysmenorrhea, painful periods, and deep dyspareunia, which is pain during intercourse.
You also have to consider infectious causes. Pelvic inflammatory disease can present with heavy bleeding, but, you would expect to see a fever or pelvic tenderness alongside it.
Good point.
And never forget iatrogenic causes, specifically the copper IUD. It's infamous for making periods heavier and more painful, unlike the hormonal coils.
Here is a concept from the sources that feels like a total trap for an overthinking trainee.
Go.
What happens if you run the FBC, the ultrasound, the TFTs, and everything comes back completely normal? My instinct is always that I just haven't looked hard enough.
Yeah, that's a common trainee fear.
Yeah.
But the AKT will test your comfort with uncertainty. The guidelines explicitly state that if all investigations are normal and no underlying structural or endocrine causes found, the diagnosis is simply heavy menstrual bleeding.
So it's just a diagnosis of exclusion.
Exactly. It operates as a diagnosis of exclusion. You do not need a definitive structural pathology to treat the symptom.
And the treatment pathway is where the heavy lifting of this topic lies, right? Looking at the stepwise management of menorrhagia, the entire algorithm hinges on a single question you ask the patient.
Yes, the decision tree.
It all comes down to, does she want to conceive right now?
That is the ultimate pivot point in your consultation. If the patient is open to contraception, your absolute, undisputed first-line management is the Mirena coil, the levonorgestrel intraordinary system.
Now, why the Mirena over just giving her the combined pill?
Because of how it delivers the hormone. The Mirena releases a steady, continuous dose of progestogen directly into the uterine cavity.
Localized.
Exactly, localized. This causes profound atrophy of the endometrial lining. The lining becomes incredibly thin, meaning there is just very little tissue to shed. It is vastly superior to oral medications for reducing blood volume.
But what if she refuses an IUD? I mean, some patients find the insertion traumatic or they simply don't want a device inside them.
Totally valid. Then you move to your second-line options, which are systemic hormones. The combined oral contraceptive pill, the COCP, or a traditional progesterone-only pill, the POP.
And those just override her cycle.
Yeah, they work by overriding her natural cycle and enforcing a much lighter, controlled withdrawal bleed.
Okay, let's explore the other branch of that decision tree. A woman sits in your clinic. She is exhausted from the bleeding, but she is actively trying for a baby. She tells you, look, do not give me contraception. What tools do we have left?
Well, you have to step away from hormonal suppression entirely. If contraception is contraindicated or unwanted, you use medications taken only during the days of heavy bleeding.
Ah, okay.
Mefenamic acid is an excellent choice. It is an NSAID, a non-steroidal anti-inflammatory drug, but it works brilliantly in the uterus by reducing the abnormally high levels of prostaglandins that are driving both the heavy bleeding and the cramping.
And the other non-hormonal option is tranexamic acid. This one fascinates me because it addresses the actual mechanics of the blood clot itself.
Exactly. Tranexamic acid is an antifibrinolytic. Think of a blood clot as a scaffolding of fibrin.
Okay, a scaffolding.
In women with heavy menstrual bleeding, an enzyme called plasmin acts like a demolition crew, breaking down that scaffolding prematurely, which causes the heavy flow.
Oh, wow.
So tranexamic acid blocks the plasmin. It basically stops the demolition crew, allowing the clots in the uterine lining to hold firm and significantly reducing the blood loss.
That makes perfect mechanical sense. And if she just needs the bleeding to stop entirely for a short period, say she has her wedding coming up, or a major surgery, you can use northisterone, which is a potent synthetic progestogen, to artificially hold the lining in place until she stops taking it.
Yes, very useful short-term tool.
Only after all these medical avenues fail do you refer to secondary care for surgical options like endometrial ablation or a hysterectomy.
Right, surgery is the last resort.
Let's dissect the pain component of this. Dysmenorrhea. The clinical notes draw a really rigid line between primary and secondary dysmenorrhea, and it all comes down to the clock.
Timing is your primary diagnostic clue here. Primary dysmenorrhea is defined as pain that occurs during menstruation.
During.
Yes. It typically presents within a year or two of menarche. The pain begins just as the bleeding starts, peaks within 24 hours, and then subsides. It is caused purely by a biochemical excess of prostaglandins, causing the uterus to contract aggressively.
So primary is pain during.
Yes. Secondary dysmenorrhea, on the other hand, is pain that starts before menstruation.
Oh,
The patient will tell you her pelvic pain begins 3 or 4 days before her period is even due and then continues through the bleeding. This timeline strongly indicates an underlying structural pathology, usually developing later in life in a woman's 30s or 40s.
that is a brilliant segue into the structural disruptors that actually cause that secondary pain. I want to look closely at two conditions that confuse a lot of people: endometriosis and adenomyosis.
They do sound similar.
Right. If I'm reading the pathophysiology correctly, they are made of the exact same disruptive material, but they are wreaking havoc in totally different locations.
That is an excellent way to conceptualize it. Both conditions involve endometrial-like tissue, the tissue that usually lines the inside of the uterus growing where it shouldn't.
Okay.
In endometriosis, that tissue is growing outside the uterus. It implants on the ovaries, forming those chocolate cysts. It wraps around the fallopian tubes. It scatters across the pelvic peritoneum, the bowel, and even the bladder.
I picture endometriosis like weeds taking over a flower bed, just spreading across the surface of all the organs.
Precisely. Now, adenomyosis is different. In adenomyosis, the endometrial tissue has grown deep into the muscular wall of the uterus itself, the myometrium.
Oh, wow.
Using your metaphor, it's as if the weeds have grown roots directly into the brickwork of the house.
That sounds incredibly painful. And the risk factors for both are identical, right? They revolve around the total number of menstrual cycles a woman experiences in her lifetime: early menarche, late menopause, nulliparity, meaning she has never been pregnant.
Because it is all about cumulative, uninterrupted exposure to estrogen. Every single month, estrogen stimulates that misplaced tissue to thicken and swell, just like the normal lining of the uterus.
Yeah.
And when the hormone levels drop, that misplaced tissue bleeds. But because it is trapped outside the uterus or deep in the muscle wall, the blood has nowhere to go. It causes intense inflammation, scarring, and severe pain.
That explains the symptom profile so clearly: chronic pelvic pain, severe dysmenorrhea, deep dyspareunia because the pelvic floor is inflamed, and subfertility because the inflammation damages the fallopian tubes.
Exactly.
Now, how does a primary care doctor investigate this? Because the notes emphasize a massive difference between what you do in GP practice versus the gold standard.
Yeah, the absolute gold standard for diagnosing endometriosis is a diagnostic laparoscopy. A surgeon physically puts a camera into the pelvis, visualizes the lesions, and biopsies them.
Oh, we can't do that.
Right? The AKT tests your role as a GP. You do not have access to a laparoscopy. Your first-line investigation in primary care is a transvaginal ultrasound.
But doesn't an ultrasound often miss endometriosis?
It misses superficial peritoneal lesions all the time.
Okay.
It is very good at spotting a large endometrioma on an ovary, or the bulky, enlarged, boggy uterus typical of adenomyosis. But a normal ultrasound does absolutely not rule out endometriosis. Despite that, it is your mandatory first step to rule out other pelvic masses before you initiate treatment.
And the initial treatment doesn't actually wait for a surgical diagnosis. You start with a 3-month trial of regular NSAIDs for the pain, and you prescribe a COCP or a progesterone-only pill to suppress ovulation and stop the cyclic bleeding of those lesions.
Yes.
You only refer to a gynecologist for a laparoscopy or GnRH analogs if that medical management fails.
That's the pathway, yeah.
Let's contrast those inflammatory lesions with something more solid: fibroids.
Fibroids.
Very.
Or leiomyomas. These are benign, solid tumors made of smooth muscle and fibrous connective tissue. They grow within the wall of the uterus.
The risk factors here are quite specific. Age is a factor, but also obesity, because adipose tissue creates peripheral estrogen, fueling the fibroids. Afro-Caribbean ethnicity is a major independent risk factor, and early puberty.
Clinically, fibroids are fascinating because their presentation depends entirely on their location and their size.
How so?
Well, many women have them and never know. They are found incidentally on a scan. But if a fibroid grows into the uterine cavity, a submucosal fibroid, it drastically increases the surface area of the lining, leading to severe, heavy menstrual bleeding.
Oh, because there's just more lining to shed.
Exactly, and if it grows large enough outward, it acts as a space-occupying pelvic mass, pressing on the bladder, causing urinary frequency, or pressing on the bowel, causing constipation.
The investigations align with what we've been discussing. a full blood count to catch the resulting anemia, and an ultrasound to measure the size and location of the fibroids. If they are particularly massive or complex, an MRI might be used in secondary care to plan surgery. I'm looking at the medical management for fibroids, and it is almost a carbon copy of the heavy menstrual bleeding pathway. Marinacoil first, NSAIDs, tranexamic acid, combined pill.
Because the goal in primary care is exactly the same.
Mm.
Control the symptom, which is usually the bleeding.
Mm.
But fibroids have an additional pharmacological option when you refer to secondary care. You can use a GnRH agonist.
Wait, hold on. I thought GnRH stimulates the reproductive system.
It does if it is released in natural intermittent pulses. But a pharmacological GnRH agonist provides a continuous, overwhelming flood of the hormone.
Oh, I see.
This overstimulates the pituitary gland until it completely burns out and downregulates its receptors. It essentially throws the woman into a temporary, medically induced menopause. Without estrogen, the fibroids shrink dramatically. Surgeons use this specifically to shrink a massive fibroid down to a manageable size before they perform a myomectomy to remove it, or a hysterectomy.
That is wild. Or they might bypass surgery and use uterine artery embolization, which sounds like something out of a sci-fi movie. A radiologist threads a catheter into the uterine artery and blocks the blood supply, basically starving the fibroid until it dies.
It's very effective, yeah.
I want to pivot now to what I consider the most conceptually difficult condition on the syllabus, polycystic ovary syndrome, PCOS. The notes explicitly state there is no known cause. For something that affects up to 10% of women, that is staggering.
It is staggering because PCOS is not a single disease pathway. It is a complex, vicious cycle of endocrine and metabolic dysfunction. The name itself is actually terrible because the cysts on the ovaries are just a symptom, not the root cause.
Let's break down the clinical features. The notes list oligomenorrhea, which means infrequent periods, or amenorrhea,
No.
hirsutism, which is excess male pattern, hair growth on the face, chest, or abdomen, severe acne, subfertility. Obesity is very common, though lean PCOS does exist.
Yes.
And then there is a very specific dermatological sign, acanthosis nigricans.
Acanthosis nigricans presents as dark, thickened, velvety patches of skin, typically found in the creases of the neck, the armpits, or the groin. When you see that, you should instantly think of profound insulin resistance.
I want to dig into that insulin resistance because it seems to be the engine driving the whole syndrome. Tell me if this analogy works. Imagine the cells in the body have rusty locks.
Okay.
The pancreas produces insulin, the keys, to open those locks and let glucose in. But because the locks are rusty, the pancreas has to pump out thousands of extra keys just to get the door open.
That is a perfect mechanical analogy. The patient has hyperinsulinemia, massive amounts of insulin circulating in the blood.
And how does that excess insulin actually affect the ovaries?
Insulin acts as a cohormone in the ovaries. It directly stimulates the cica cells of the ovary to produce excessive amounts of androgens, like testosterone.
Oh, wow.
Furthermore, high insulin suppresses the liver from making sex hormone-binding globulin, or SHBG.
Right.
Normally, SHBG acts like a sponge, soaking up free testosterone in the blood.
Right.
With low SHBG, there is nothing to soak it up, leaving high levels of active, free testosterone ravaging the system, which causes the acne and the hirsutism.
And that high testosterone completely disrupts the delicate orchestration of ovulation, meaning the follicles never mature and release an egg, which is why they back up in the ovary and look like cysts on an ultrasound.
Exactly.
This brings us to how you diagnose it for the exam, because you cannot just run a blood test and call it a day. You have to use the Rotterdam criteria.
The Rotterdam criteria are absolute gold for the AKT. To diagnose PCOS, a patient must meet 2 out of the 3 following criteria.
Okay, what are they?
Criterion 1, polycystic ovaries visible on an ultrasound. Criterion 2, oligovulation or anovulation, meaning her periods are irregular or entirely absent. Criterion 3, hyperandrogenism. This can be clinical, like obvious hirsutism, or biochemical, meaning raised testosterone levels on a blood test.
I need to highlight a major trap here for the trainees. Based on those criteria, you only need 2. That means a patient can have irregular periods and high testosterone, and she is officially diagnosed with polycystic ovary syndrome, even if her ovaries look completely normal on an ultrasound.
Yes. Do not let an exam question trick you into ruling out PCOS just because the ultrasound is clear. If she has the biochemical markers and the absent periods, she meets the criteria.
Now, there is a sinister long-term risk associated with PCOS that we touched on briefly earlier, endometrial cancer. Walk me through the pathology of why failing to ovulate leads to uterine cancer.
It comes back to the concept of unopposed estrogen. In a healthy menstrual cycle, the first half is dominated by estrogen, which acts like a bricklayer, constantly building up the endometrial lining.
Yeah.
When ovulation occurs, the empty follicle becomes the corpus luteum and starts producing progesterone. Progesterone acts like the mortar. It stabilizes the bricks, stops the lining from growing any thicker, and prepares it for a fertilized egg.
And if no egg implants, the progesterone drops and the whole wall comes down as a period.
Exactly. But in PCOS, because the high testosterone halts ovulation, there is never a corpus luteum, and therefore there is never any progesterone.
Oh, wow.
You just have constant, uninterrupted estrogen continuing to lay down bricks month after month, year after year. The lining gets thicker, increasingly unstable, and eventually the cells begin to mutate into endometrial hyperplasia, which is the direct precursor to endometrial cancer.
That is terrifying, but it makes perfect physiological sense. So our management of PCOS must address that risk. Looking at the treatment pathways, I see the same bifurcation we saw with menorrhagia. Everything depends on whether the patient wants to get pregnant.
If she is actively trying to conceive, your goal is to force the ovaries to ovulate. You refer her for ovulation induction. They will use medications like clomiphene, which blocks estrogen receptors in the brain, tricking the pituitary into pumping out more FSH to stimulate the follicles.
Okay.
Or they use metformin.
Metformin, the diabetes drug.
Yes, because remember your rusty locks analogy. Metformin clears the rust. It improves insulin sensitivity, which lowers the insulin levels, which in turn lowers the testosterone. Often, just lowering the testosterone is enough to allow the ovaries to naturally resume ovulation without any other fertility drugs.
But what if she sits in your office and says, look, I am 22, I am not thinking about a baby, I just want this facial hair gone and I want to protect myself from cancer?
Then your management shifts entirely to symptom control and endometrial protection. To force a regular shedding of the uterine lining and prevent that cancer risk, you put her on a combined oral contraceptive pill.
Right.
It introduces the synthetic progestogen she is missing, stabilizing the lining and enforcing a withdrawal bleed.
And what about the hirsutism?
The standard COCP helps by increasing that SHBG sponge we talked about, soaking up free testosterone. But if the hair growth is severe, you use a specific pill called cosaprendiol.
Cosaprendiol.
Yeah. It contains a powerful anti-androgen that actively blocks testosterone at the hair follicle. However, you must counsel the patient heavily. Cosaprendiol is highly teratogenic. It will cause severe defects in a male fetus, so it is strictly contraindicated if there is any chance of pregnancy.
If systemic medications aren't an option, the notes mention topical eflornithine cream, which you rub directly onto the face to inhibit the enzyme responsible for hair growth.
Yes, that's a good local option.
While we are on the topic of excess hair, I want to clarify a very specific dermatological distinction the guidelines make. Hirsutism versus hypertrichosis. They are not the same thing.
No, they are completely different pathologies.
Right.
Hirsutism is androgen-driven. It is the development of terminal, thick hair in a male pattern distribution on a woman, the chin, the upper lip, the chest, the lower abdomen.
Right.
It's caused by conditions like PCOS, Cushing syndrome, or congenital adrenal hyperplasia. We quantify its severity clinically using the Ferriman-Galway scoring system.
Okay. Hypertrichosis, on the other hand, has absolutely nothing to do with androgens. It is a generalized excessive growth of hair anywhere on the body affecting both men and women, the classic werewolf syndrome.
The causes of hypertrichosis are fascinatingly diverse. Severe anorexia nervosa can cause the body to grow a fine layer of linigo hair to preserve heat. A metabolic condition called porphyria cutanea tarda causes it. But most commonly in an exam setting, it is drug-induced. Medications like minoxidil, cyclosporin, or diazoxide are classic triggers.
Keeping those two distinct will save trainees a lot of points.
Absolutely.
All right, conditions like PCOS, severe endometriosis, and fibroids lead us inevitably into one of the most emotionally devastating consultations a GP can have, the fertility journey. Let's explore the investigations for infertility and premature ovarian insufficiency.
Let's start with the definitions, as they really dictate your referral pathways. Primary infertility refers to a couple who has never conceived a pregnancy.
Never.
Secondary infertility means the woman has previously conceived, even if that pregnancy ended in a miscarriage or an ectopic pregnancy, but they are now struggling to conceive again.
The statistical baseline is actually very reassuring, though, and it's our job to communicate this to panicked couples. 84% of couples will conceive within 1 year of regular, unprotected sexual intercourse.
Yes, that's a key stat.
By the end of 2 years, that number rises to 92%. But for that remaining 8%, the causes are split across several categories.
And it is vital to remember that it takes two. A massive 30% of infertility cases are due entirely to male factors, specifically sperm disorders.
Wow, 3%.
On the female side, ovulatory disorders like PCOS account for a large portion. Then you have tubal damage, often from previous undetected pelvic infections, and uterine structural issues like severe adenomyosis or fibroids. And then, incredibly frustratingly for the patients, about 25% of cases are completely unexplained. All the tests come back pristine, but the pregnancy doesn't happen.
So as a GP, when do we actually intervene and start ordering these tests?
The standard guideline is to initiate investigations after 1 year of trying to conceive. However, the AKT loves to test the exceptions. You investigate earlier after just 6 months if the female partner is over the age of 36, because ovarian reserve drops precipitously as a woman approaches 40.
You also investigate immediately if there is a blazing red flag in their history. Like, if the woman has a known history of pelvic inflammatory disease, you assume tubal scarring until proven otherwise.
Exactly.
If the male partner had undescended tests as a child or previous groin surgery, you investigate immediately.
Right, don't wait the year in those cases.
This brings us to the investigations themselves, and I want to spend significant time here because there is a mathematical concept regarding progesterone testing that trips up almost everyone.
Oh, the day 21 test.
Yes.
Yeah.
The guidelines state you must test day 21 progesterone to confirm ovulation, but that name is a massive misnomer, isn't it?
Day 21 progesterone is one of the most dangerously misleading terms in all of primary care. The actual clinical goal is to measure progesterone during the mid-luteal phase.
Mid-luteal.
Yes. Progesterone is produced by the corpus luteum only after an egg has been released. It rises, peaks right in the middle of the luteal phase, and then crashes, triggering the period. We need to catch it at that peak to prove an egg was actually released.
I want the listener to actively engage with this puzzle. Let's say you have a patient sitting across from you. She meticulously tracks her periods, and she tells you her cycle is exactly 35 days long. Every 35 days, she bleeds.
Okay.
If you tell her to go to the phlebotomist on day 21 of her cycle, what will happen?
Her blood test will come back showing 0 progesterone. She will be falsely diagnosed as an ovulatory. You might refer her for unnecessary fertility treatments, all because she hadn't actually reached ovulation by day 21.
To get the math right, we have to look at the fixed physiological reality of the menstrual cycle.
The cycle has 2 halves. The first half, the follicular phase, is highly variable. It can take 10 days to grow an egg, or it can take 25 days. But the second half of the cycle, the luteal phase, the lifespan of the corpus luteum, is almost universally fixed at exactly 14 days across all women, regardless of how long their total cycle is.
So ovulation always occurs exactly 14 days before the start of the next period.
Yes. And because we want to measure the progesterone at its absolute peak, we want to test exactly in the middle of that 14-day luteal phase. Half of 14 is 7. Therefore, we must draw the blood exactly 7 days before her next expected period.
Let me walk through the formula. You take the total cycle length and you subtract 7.
Simple as that.
If a woman has a textbook 28-day cycle, 28 minus 7 is 21. That is the only reason it is historically called the day 21 test.
Precisely. It assumes everyone is textbook.
But let's go back to our patient with the 35-day cycle. 35 minus 7 is 28. You must tell her to get her blood drawn on day 28 of her cycle.
Let's do another one. A patient with a short 24-day cycle.
Okay, 24 minus 7 is 17. She needs her blood test on day 17.
Exactly. If you understand the physiology that you are counting backward from the end of the cycle to find the middle of the luteal phase, you will never be tricked by an AKT question offering multiple dates.
The other female investigations include the standard endocrine panel, FSH, LH, prolactin, and TFTs, and crucially, a chlamydia screen. Now, why do we screen an asymptomatic woman trying for a baby for chlamydia?
Because chlamydia is a silent destroyer of fallopian tubes. It can cause an asymptomatic ascending infection that leaves the tube scarred and blocked. Even if she clears the infection naturally, the physical damage remains.
Wow.
If the screen is positive, or if she has a history of it, secondary care will perform a hysterosalpingogram flushing dye through the uterus and tubes under X-ray to check if the pathway is open.
Let's look at the male half of the equation. The primary investigation is a semen analysis. The guidelines have a specific quirk here. If the first analysis comes back abnormal, you do not panic and refer immediately. You wait and repeat it. Why the delay?
Because spermatogenesis, the entire manufacturing process of a sperm cell from a germ cell to a fully mature, swimming sperm takes roughly 72 to 74 days.
Over 2 months.
Yeah. If a man had a severe flu with a high fever 2 months ago, his current sperm count will be disastrous.
Mhm.
You have to wait 3 months to allow an entirely new batch of sperm to be manufactured and assess the new baseline.
When the lab report does come back, it uses very specific terminology. It doesn't just say bad sperm. It breaks down the exact nature of the failure. I want to translate these terms because they are highly testable.
The prefixes hold the key.
Let's start.
First, aspermia. The prefix A means none. This means no semen is produced or ejaculated whatsoever.
Next is azoospermia. This means semen is ejaculated, but there is absolutely zero sperm within the fluid. This is what you actively want to see after a successful vasectomy. Though the notes remind us that a vasectomy has a failure rate of 1 in 2,000, and you must test the semen at 8 and 12 weeks post-procedure to confirm azoospermia before they can stop using contraception.
Then we get into the defects of the sperm themselves. Oligospermia means oligo, or few. It is a low sperm count, insufficient numbers to likely achieve fertilization.
Asthenozoospermia refers to a motility issue. The sperm are present in good numbers, but they are sluggish. They lack the forward progression needed to swim through the cervix, up the uterus, and into the fallopian tubes.
Necrospermia is a bleak term. The sperm are present in the ejaculate, but they are entirely dead and non-viable.
And finally, teratozoospermia. Terato refers to monster or abnormal. This means the sperm have abnormal morphology. They might have two heads or a kinked tail, making it physically impossible for them to penetrate the egg's outer shell.
If these male factors are identified, the secondary care pathway might involve intracytoplasmic sperm injection, or ICSI, where the embryologist selects one single morphologically perfect sperm and physically injects it directly into the harvested egg.
Before we leave the topic of fertility, we have to discuss the most abrupt end to it. Premature ovarian insufficiency, or POI. This is when menopause occurs in a woman under the age of 40. The psychological impact of this diagnosis is immense, which is why the diagnostic criteria are so rigorous.
You absolutely cannot diagnose POI based on a single blood test or a missed period. The criteria mandate that you must have 2 separate blood tests showing an FSH level greater than 30, and these tests must be taken 4 to 6 weeks apart.
Why FSH? Why not measure estrogen directly?
Because FSH, follicle-stimulating hormone, is the brain screaming at the ovaries. When the ovaries fail and stop producing estrogen, the brain senses the lack of estrogen and assumes it just needs to try harder.
Oh, okay.
It pumps out massive amounts of FSH, trying to stimulate follicles that simply aren't there anymore. And FSH over 30 is the hallmark of ovarian failure.
And the management is critical. You don't just offer sympathy, you have to intervene medically.
These women require hormone replacement therapy. And I want to emphasize, this is not just to treat hot flushes. A woman in her 20s or 30s who loses her estrogen is at massive, immediate risk of severe osteoporosis and early cardiovascular disease.
So it's about life preservation.
Exactly. You must prescribe HRT to replace the hormones her body should naturally be making, and she must remain on it until the average age of natural menopause, which is 51.
Okay, we mentioned chlamydia a moment ago as a silent destroyer of fertility. That brings us logically to acute pelvic infections and the various presentations of vaginal discharge. Let's look at pelvic inflammatory disease, PID.
PID is an ascending infection. It starts in the vagina or cervix, usually introduced via a sexually transmitted infection like chlamydia or gonorrhea, and it travels aggressively upwards into the normally sterile environment of the uterus, the fallopian tubes, and the ovaries.
We talked about the long-term complication of tubal scarring leading to infertility or ectopic pregnancies, but the acute presentation is what brings them into the GP surgery. They present with bilateral lower abdominal pain, deep dyspareunia, a fever, and often a heavy, purulent vaginal discharge. Yes. When you examine them, the classic sign is cervical excitation. When you gently move the cervix during a bimanual exam, it stretches the inflamed pelvic peritoneum, causing exquisite pain.
There's also a highly testable specific complication of PID called Fitzhugh-Curtis syndrome.
Perihepatitis.
Yes, the infection and the resulting inflammatory exudate track all the way up the right side of the abdomen underneath the diaphragm and inflame the capsule of the liver. It forms these classic violin string adhesions between the liver and the abdominal wall.
So the clinical scenario in the exam will be a young, sexually active woman who presents with pelvic pain, but then she starts complaining of sharp right upper quadrant abdominal pain, right where her gallbladder is. If you don't connect the pelvic infection to the liver capsule, you will misdiagnose her with biliary colic.
It's a classic trap.
Let's look at the management of PID. Because reading this antibiotic regimen, it feels like we are deploying a nuclear option for an outpatient.
It is an incredibly aggressive regimen because the stakes, permanent infertility, and chronic lifelong pelvic pain are just so high. The UK guidelines for outpatient management of PID are very clear. The first-line treatment is a triplet of antibiotics.
It starts with a single intramuscular injection of ceftriaxone.
The ceftriaxone is there specifically to obliterate gonorrhea. It breaks down the bacterial cell wall. Even if the swab results aren't back, you assume gonorrhea is present and hit it with the IM injection.
Then you send them home with 2 oral antibiotics to take for 14 days. Oral doxycycline, which shuts down the protein factories of chlamydia, and oral metronidazole.
The metronidazole is crucial. As the infection ascends into the deep, oxygen-deprived pockets of the pelvis and the fallopian tubes, anaerobic bacteria from the normal vaginal flora join the party.
Lovely.
Yeah, metronidazole disrupts the DNA of these anaerobes.
So ceftriaxone IM plus oral doxycycline plus oral metronidazole for a fortnight. What if they are allergic or can't tolerate that?
The second-line options substitute the doxycycline. You can use oral ofloxacin plus metronidazole or oral levofloxacin plus metronidazole, but that first-line triplet is the one the examiners will really look for.
Let's move from ascending pelvic infections to isolated vaginal discharge. This is pure pattern recognition. The guidelines provide these perfectly distilled blue text buzzwords that you just have to know. Let's start with the most common, candida or vaginal thrush.
Thrush is a fungal infection. The discharge is classic, thick, white, and often described as looking like cottage cheese. But the primary symptom is usually intense, maddening purtis itching.
The buzzwords for the exam are satellite lesions on the vulva, little red spots spreading out from the main area of redness.
You also need to know the triggers. The yeast feeds on sugar. If a patient presents with recurrent thrush, you absolutely must check her HbA1c to rule out undiagnosed diabetes mellitus.
Good point.
Other triggers include pregnancy, recent broad-spectrum antibiotics wiping out the protective lactobacilli, or immunosuppressive drugs.
The standard treatment is a single oral dose of fluconazole or a topical clotrimazole pessary if she is pregnant. But what about the patient who comes back every 2 months? The notes define recurrent thrush as more than 4 episodes in a single year.
That requires a much more prolonged approach. You have to initiate an induction and maintenance regime. You prescribe 3 doses of oral fluconazole to be taken every 3 days to completely clear the fungal burden. Then, you put her on a maintenance dose of 1 fluconazole tablet every single week for 6 solid months.
Let's contrast thrush with bacterial vaginosis, BV. It is entirely different.
BV is not an infection in the traditional sense. It is a dysbiosis. The healthy acid-producing lactobacilli in the vagina are wiped out and replaced by an overgrowth of anaerobic bacteria, primarily Gardnerella vaginalis.
The discharge here is thin, watery, and grayish. But the defining feature is the smell. The exam will describe a fishy or offensive odor.
The key differentiator clinically is the vaginal pH. A healthy vagina is highly acidic, with a pH under 4.5. Because the acid-producing bacteria are gone in BV, the pH rises above 4.5.
The sensory details for BV are unforgettable. There is the microscopic buzzword, clue cells. If you look at a swab under a microscope, you see the normal epithelial cells completely studded and obscured by tiny bacteria looking like they are covered in sand. And then there is the whiff test.
Ah, yes, the whiff test. If you add a drop of potassium hydroxide to the vaginal swab on a slide, it instantly volatilizes the amines produced by the bacteria, and the entire consultation room will suddenly smell overwhelmingly of fish.
The treatment for BV targets those anaerobes. Oral metronidazole for 5 to 7 days, or a topical metronidazole or clindamycin gel. The third major discharge to know is Trichomonas vaginalis.
This is a sexually transmitted motile parasite. The discharge is distinct. It is green, yellow, and frothy. The pH is also elevated, like in BV, greater than 4.5.
But the golden ticket buzzword for trichomonas, the one that will guarantee you the point on the exam, is the appearance of the cervix.
The strawberry cervix. The parasite causes intense local inflammation, leading to tiny punctate macular hemorrhages all over the cervix. When you look with a speculum, it literally looks like the surface of a strawberry.
And because it is a systemic parasite, you treat it with systemic oral metronidazole. Before we move on, the guidelines add a stark reminder. If a patient presents with a truly foul, putrid-smelling discharge that doesn't fit these neat categories, you must perform a speculum exam to rule out a retained foreign body, like a forgotten tampon. The smell is unmistakable tissue necrosis.
Definitely. You don't want to miss that.
Now, since we are looking at the cervix, let's differentiate some common cervical lesions that can cause discharge or postcoital bleeding but aren't actually infections.
The cervix is a dynamic organ. When you do a speculum exam, you might see Nabatean cysts. These are completely benign, mucus-filled retention cysts on the surface of the cervix. They look like smooth, translucent little pearls.
Do they need treatment?
They are entirely harmless and require absolutely zero treatment unless they grow so large they become symptomatic, which is rare.
You might also see a cervical polyp, a little fleshy finger of benign tissue protruding from the cervical canal. These are notorious for bleeding after intercourse because they're easily traumatized. GPs usually twist these off and send them for histology, just to be absolutely certain there are no malignant cells.
Right.
But the most physiologically interesting lesion is the cervical ectropion.
And ectropion is a perfect example of normal anatomy appearing in a hostile environment. The inside of the cervical canal is lined with fragile glandular columnar epithelium cells designed to secrete mucus.
Okay.
The outside face of the cervix, extending into the vagina, is lined with tough, squamous epithelium designed to withstand the acidic environment and the friction of intercourse.
In an ectropion, that delicate internal lining grows outward, spilling over the edge and onto the face of the cervix.
Exactly. And because that glandular tissue is incredibly rich in blood vessels and not designed for the acidic vaginal environment, it appears angry, bright red, and bleeds very easily when touched, such as during intercourse or when taking a smear test.
The guidelines note that this is entirely physiological and driven by high estrogen. You see it constantly in teenagers and pregnant women, and in women taking the combined oral contraceptive pill. It is not cancer. Usually, it needs no treatment. If the discharge or bleeding is ruining her quality of life, secondary care can use silver nitrate or cryotherapy to ablate that fragile tissue so the tough squamous cells can grow back over it.
Yeah, that's the usual approach.
Talking about looking at the cervix transitions us perfectly to what is arguably the most vital preventative program in the UK, the cervical screening program. The goal is brilliant, catching precancerous changes, but the algorithm can feel like a labyrinth. Let's map it out.
The first fundamental shift to understand is that the UK no longer looks primarily at the cells. The primary test is now for high-risk human papillomavirus, or HRHPV. We are hunting for the virus that causes the cancer, long before it actually damages the cervical cells.
The logistics are strict. Women aged 25 to 49 are called every 3 years. From 50 to 64, it's every 5 years. HIV-positive patients are screened annually because their compromised immune system cannot clear the HPV virus effectively. And importantly, trans men who have retained their cervix are absolutely entitled to and require screening.
A vital rule for primary care. Women over the age of 65 cannot suddenly request a smear test if their previous routine tests were normal. The risk of developing new cervical cancer at that age without prior HPV infection is vanishingly small.
Now, what about delaying a smear? You have a patient booked in, she takes time off work, she arrives in your clinic. Under what circumstances do you have to tell her, I'm sorry, I cannot do this test today?
You must delay if she is actively menstruating. Blood entirely obscures the sample. You must delay if she has given birth, had a miscarriage, or a termination of pregnancy within the last 12 weeks. The cervix undergoes massive structural remodeling during that time, and the cells will look highly abnormal and dyskaryotic, leading to false positives.
Obviously, you do not perform a routine smear if she is currently pregnant. And as we discussed with PID, if she presents with an active, purulent pelvic infection, you must treat the infection first. The massive influx of inflammatory white blood cells will completely blind the lab's ability to read the sample.
Exactly.
I want to pause here and emphasize a terrifying statistic from the guidelines. The cervical screening program is incredible, but it misses up to 15% of adenocarcinomas.
Yes. Squamous cell carcinomas happen on the outer face of the cervix where the brush easily collects them. Adenocarcinomas develop higher up, deep inside the cervical canal, out of reach of the brush. If a patient presents with classic red flag symptoms like persistent postcoital bleeding, you must refer her for investigation regardless of whether she just had a completely normal smear test last month. A normal smear does not rule out cancer in a symptomatic patient.
Okay, let's walk through the HPV flowchart. This is highly testable. I want the listener to visualize this as a decision tree. Scenario 1. You take the sample, send it to the lab, the result comes back, HPV negative.
That is the best possible outcome. No virus means virtually zero risk of developing cervical cancer in the near future. She returns a routine recall, receiving her next invitation in 3 or 5 years.
Scenario 2. The lab tests the sample and it is HPV positive.
Because the virus is present, the lab automatically, using that exact same sample vial, performs cytology. They look at the cells under the microscope. If they see dyskaryosis abnormal, precancerous cell changes, she is referred straight to colposcopy for a specialist to examine her cervix with a microscope and potentially biopsy or remove the abnormal tissue.
That makes sense. Virus present, damage present.
Yeah.
Refer. Here is where the labyrinth gets tricky. Scenario 3. The sample is HPV positive. The virus is there. But the cytology comes back negative. The cells are completely healthy and normal. What is the plan?
You do not refer to colposcopy. The virus is present, but it hasn't caused any damage yet. In the vast majority of women, the immune system will recognize the virus and clear it naturally. So you wait. You invite her back for a repeat smear in exactly 12 months.
So she comes back at year 1. We test again. If it's negative, great, her immune system won. But what if it is still HPV positive at year 1?
We stay calm. The lab runs the cytology again. If the cells have now become abnormal over that year, she goes to colposcopy. But if the cells are still normal, we wait again. We invite her back for a third test in another 12 months. We are now at year 2.
Okay, we're at year 2. She has been walking around with high-risk HPV for 24 months. We run the test. If it finally clears, she goes back to routine recall. But what if the lab report comes back and she is still HPV positive at year 2?
That is the end of the waiting game. If the virus has persisted for 2 full years, the risk of it eventually causing cellular mutations is too high. She is referred directly to colposcopy. And here's the crucial detail the examiners will test you on. At this year 2 stage, the lab does not even bother checking the cytology. Persistent HPV positivity for 24 months is, in itself, an automatic criteria for a colposcopy referral.
That flowchart is a masterpiece of public health logic once you understand the timeline of viral clearance. Briefly, the notes mention breast cancer screening. It is much more straightforward.
Very simple. Women aged 50 to 70 are routinely invited for a mammogram every 3 years. Women over the age of 70 are no longer automatically called, but they are absolutely allowed to request a screening every 3 years if they choose to.
We've spent all this time talking about screening, which is designed to catch pre-cancerous changes. But what happens to the patient who slips through the cracks, the patient whose system fails to regulate? We are moving into the red flags for active gynecological malignancies.
Let's start with cervical cancer. It is predominantly a squamous cell carcinoma. The risk factors are essentially a list of anything that increases exposure to HPV or decreases the body's ability to fight it.
Multiple sexual partners, an early age of first intercourse, and obviously not getting the HPV vaccine. But smoking is a massive risk factor here, which people don't always associate with the cervix.
Nicotine and its metabolites concentrate in the cervical mucus and actively deplete the local immune cells, the Langerhans cells in the cervix. A smoker is vastly less likely to clear an HPV infection naturally. And of course, systemic immunosuppression like HIV is a major risk.
The cancer progresses sequentially from cervical intraepithelial neoplasia, or CIN 1, 2, and 3, which is confined to the surface layer until it breaches the basement membrane and becomes invasive cancer. The symptomatic red flags that mandate an urgent 2-week wait referral are postcoital bleeding, intermenstrual bleeding, a blood-stained foul discharge, and eventually deep pelvic pain as the tumor invades surrounding tissues.
Right.
Now let's contrast the visible, accessible cervix with the silent killer of the pelvis, ovarian cancer.
Ovarian cancer is notoriously devastating precisely because it grows in the vast open space of the peritoneal cavity. By the time it causes severe symptoms, it is often advanced. The most common type is an epithelial cell tumor.
I am looking at the risk factors, and I am seeing our old nemesis, continuous, uninterrupted ovulatory cycles, nulliparity, early menarche, late menopause. It seems like the physical trauma of the ovary bursting open every month to release an egg, over and over for 40 years without the break of a pregnancy, increases the risk of those epithelial cells mutating during the repair process.
That is exactly the prevailing theory. Other risks include endometriosis, obesity, taking HRT, smoking, and a very strong genetic component. If a patient has a family history of breast or ovarian cancer, or carries the BRCA1 or BRCA2 gene mutations, her risk is exponentially higher.
The symptoms are the most treacherous part of this disease for a GP because they sound exactly like benign gastrointestinal issues. Bloating, feeling full quickly after eating just a few bites, unexplained weight loss, urinary frequency because the mass is pressing on the bladder.
Yes, very nonspecific.
This brings us to a massive clinical pearl for the AKT, the guideline regarding irritable bowel syndrome.
This is a scenario you will see in the exam and in real life. A 55-year-old woman presents to your clinic complaining that she has suddenly developed IBS. She is bloated, her bowel habits have changed, she has abdominal discomfort.
Okay.
You must remember, irritable bowel syndrome is a disease of young adults. It extremely rarely starts de novo in a woman in her 50s. If a postmenopausal woman presents with new-onset IBS symptoms, you must suspect an ovarian tumor pressing on her bowel or causing a site's fluid buildup in the abdomen.
Your immediate investigations in primary care are a CA-125 blood test and a pelvic ultrasound. If the CA-125 is elevated, specifically greater than 35, she requires an urgent referral. Let's move to endometrial cancer. We discussed the mechanism for this earlier when we talked about PCOS. It is all about unopposed estrogen.
The risk profile is a perfect reflection of that pathology. Anything that increases estrogen or removes the protective effect of progesterone. Obesity is a massive risk factor because peripheral fat cells contain an enzyme called aromatase, which continuously converts circulating androgens into estrogen.
Early menarche, late menopause, nulliparity. We mentioned PCOS. Tamoxifen is another huge one because while it blocks estrogen in the breast tissue, it actually acts as a weak estrogen stimulator in the uterus. And there is a genetic link here too. HNPCC, also known as Lynch syndrome, carries a very high risk of endometrial cancer.
The cardinal presentation, the red flag that should trigger an immediate alarm bell in your head, is postmenopausal bleeding.
The rule is absolute. Any episode of vaginal bleeding in a woman who is more than 12 months postmenopausal, especially if she's over 55, requires an urgent 2-week wait referral for a transvaginal ultrasound to measure the endometrial thickness and likely a biopsy. You assume endometrial cancer until the biopsy proves otherwise.
Absolutely.
Finally, in the cancer section, vulval and vaginal cancers. These are rarer, mostly squamous cell carcinomas.
They share risk factors with cervical cancer, specifically HPV infection. But for vulval cancer, there's another major precursor, lichen sclerosis. This is a chronic, intense autoimmune inflammatory skin condition that thins and damages the vulval tissue, significantly increasing the risk of malignant transformation.
The red flags here that prompt an urgent referral are an unexplained, palpable vulval lump, a non-healing ulcer, spontaneous bleeding from the vulva, or a palpable mass in the vagina itself.
Okay, we've reached the final major phase of our deep dive,
Hmm.
the later years.
The later years, yeah.
We are moving into the post-menopausal phase of life. The ovaries finally power down, estrogen production plummets, and this hormonal withdrawal leads to profound systemic and biomechanical changes across the entire body. Let's start with the definition. Menopause is officially a retrospective diagnosis. You can only diagnose it after a woman has gone 12 consecutive months without a single menstrual period. The tumultuous years leading up to that final period, characterized by wildly fluctuating hormone levels and irregular bleeding, is the perimenopause. And if this cessation of ovarian function happens before the age of 40, it is premature menopause, or POI.
Estrogen is incredibly protective. It maintains bone density, it keeps blood vessels pliable, it supports the collagen in the pelvic floor. Once it's gone, the long-term health risks skyrocket. Postmenopausal women face vastly increased risk of osteoporosis, cardiovascular disease, stroke, and urogenital atrophy.
The immediate clinical challenge, however, is managing the symptoms, which can be utterly debilitating. They are grouped into 3 categories. First, vasomotor symptoms, the sudden overwhelming hot flushes, night sweats, palpitations, and nausea caused by the brain's temperature regulation center misfiring without estrogen.
Then you have urogenital symptoms. The vaginal tissue becomes thin, dry, and fragile, leading to severe dyspareunia. The urethra is also estrogen dependent, so women develop urinary frequency, urgency, and recurrent UTIs.
And finally, the psychological symptoms. Profound mood swings, depression, irritability, brain fog, and short-term memory loss.
Diagnosing it is usually clinical. If a woman is over 45 and presenting with classic hot flushes and irregular periods, you do not need to draw blood. The guidelines state you can diagnose perimenopause clinically. You only check FSH if she is under 40 to rule out POI, or between 40 and 45 if the presentation is atypical. So how do we manage this? Because I know HRT is the gold standard, but the guidelines always emphasize starting with lifestyle.
Lifestyle interventions are the foundation. Weight loss, regular weight-bearing exercise to protect the bones, wearing layers of light clothing, keeping the bedroom cool, and identifying triggers for hot flushes, which often include caffeine, alcohol, or spicy foods.
But when lifestyle isn't enough, hormone replacement therapy is the most effective treatment for vasomotor symptoms. Now, there is a very explicit warning in the AKT notes regarding non-hormonal treatments. In the past, doctors used to hand out antidepressants, SSRIs, or SNRIs, like venlafaxine, to treat hot flushes. The current guidelines state do not routinely prescribe these for vasomotor symptoms alone.
They're not highly effective for the physical flushes and carry their own side effect profiles. However, if a patient cannot take HRT, for example, if she has a personal history of hormone receptor-positive breast cancer, you have to use alternatives. In that specific scenario, the medications tibolone or clonidine are your non-hormonal options for flushes.
For the psychological symptoms, HRT helps stabilize the mood, but cognitive behavioral therapy is also strongly recommended and evidence-based for menopausal mood disorders. And if her only complaint is severe vaginal dryness and pain during sex, you don't need to expose her whole body to systemic HRT.
Exactly. You use localized topical vaginal estrogen. It comes as creams, pessaries, or a vaginal ring. It stays local, restores the tissue, and carries virtually zero systemic risk. You can combine it with standard non-hormonal lubricants and moisturizers.
Now, a logistical nightmare for many patients, contraception during the perimenopause. Because her periods are irregular, she never knows if she is actually sterile yet. The guidelines provide a rigid rule based entirely on age.
You must memorize this timeline. If a woman has her final menstrual period under the age of 50, she must continue using reliable contraception for 24 months after that last bleed. The younger ovaries can occasionally fire off a rogue egg even after a year of silence. If she has her final menstrual period over the age of 50, she only needs to use contraception for 12 months after that last bleed.
Okay, let's dive into the prescribing logic of HRT. The overarching principle is the lowest effective dose for the shortest necessary time, reviewed at 3 months after starting and then annually thereafter. The entire decision of what type of HRT to prescribe rests on a single anatomical question.
Does the patient have a uterus? That is your starting point. If the woman still have her uterus intact, she absolutely must be prescribed combined HRT. That means she takes estrogen to relieve her symptoms, but she must also take progesterone. As we discussed endlessly with endometrial cancer, giving a woman unopposed estrogen will cause the lining of her uterus to thicken, mutate, and turn cancerous. The progesterone is there entirely to protect the uterine lining.
If she is perimenopausal and still having occasional periods, she takes cyclical combined HRT, which gives her a regular monthly bleed. If she's a fully postmenopausal, she takes continuous combined HRT, which gives her a stable dose of both hormones every day and stops all bleeding.
Now, if the woman does not have a uterus, if she has had a hysterectomy for fibroids or prolapse or cancer, the risk of endometrial cancer is zero. Therefore, she does not need the protective progesterone. She can be prescribed estrogen-only HRT, which has a slightly safer long-term profile.
The contraindications for HRT are highly testable because they deal with serious morbidity. You cannot prescribe systemic HRT if she has a history of estrogen-dependent cancers like breast or endometrial cancer. You cannot prescribe it if she has active liver disease because the liver metabolizes the hormones. Undiagnosed vaginal bleeding is an absolute contraindication until you rule out cancer. And crucially, vascular risks. Untreated hypertension, a history of stroke, myocardial infarction, or a history of blood clots like a DVT or a pulmonary embolism.
Though it is worth noting for your clinical practice, if a woman has a mild risk factor for clots, transdermal estrogen patches or gels absorbed through the skin bypasses the liver's clotting cascade and carries a much lower DVT risk than oral tablets.
Yeah, let's finish with the mechanical failures that happen as that estrogen declines. The connective tissue, the fascia, the ligaments supporting the pelvic organs all lose their elasticity. They start to stretch and fail. Let's look at pelvic organ prolapse. Imagine the pelvic floor as a muscular hammock holding up 3 distinct compartments.
The risk factors for tearing that hammock include advancing age, declining estrogen, obesity, putting constant downward pressure on the floor, and a history of traumatic vaginal deliveries or hyperity.
The anterior compartment sits at the front. If the tissue here weakens, the bladder or the urethra bulges downward into the front wall of the vagina. We call that a cystocele or a urethrocoele.
The middle compartment is the uterus itself. If the apical ligaments fail, the cervix and uterus literally drop down the vaginal canal, sometimes protruding entirely outside the body.
And the posterior compartment is at the back. If that wall weakens, the rectum bulges forward into the back wall of the vagina, creating a rectocele. The symptoms are purely mechanical. Women describe a heavy, dragging sensation in the pelvis, a feeling of something coming down, or they can physically feel a lump. A cystocele will cause urinary retention or incontinence, while a rectocele might require the woman to physically press on the back wall of her vagina just to empty her bowels.
Management is a stepped approach. You start with pelvic floor physiotherapy to strengthen the hammock. If that fails, or if she is elderly and frail, you can insert a vaginal pessary, a silicone ring that acts like an internal scaffolding to hold the organs up. Ultimately, definitive treatment is surgical repair.
Which leads us directly into our final clinical scenario, urinary incontinence. The exam requires you to differentiate the types perfectly because the treatments are wildly different. Stress incontinence is purely mechanical. The sphincter is weak. When the patient exerts sudden intra-abdominal pressure, she coughs, she laughs, she sneezes, or jumps on a trampoline, urine leaks out.
Urge incontinence, on the other hand, is neurological and muscular. It is an overactive detrusor muscle in the bladder. The patient feels a sudden, overwhelming, uncontrollable urge to urinate, and if she's standing next to a toilet, she will completely void her bladder.
You also have mixed incontinence, which is a combination of both, and overflow incontinence, where the bladder is chronically in retention, gets too full, and just constantly dribbles. The management timelines for stress and urge incontinence are the last major trap of the syllabus.
For stress incontinence, your initial management is lifestyle. Lose weight to reduce pressure on the bladder. But the primary intervention is neuromuscular hypertrophy. You prescribe pelvic floor muscle training. And the timeline is rigorous. She must perform 8 specific contractions 3 times every single day for a minimum of 3 full months before you can declare the treatment a failure.
3 months of pelvic floor exercises for stress incontinence. If that fails, you can try the medication duloxetine or refer for a surgical mid-urethral sling. Now look at urge incontinence. The lifestyle advice here is about reducing detrusor irritants. Cut out caffeine, stop drinking massive volumes of water before bed, but the primary intervention is entirely different. It is bladder retraining.
You are trying to neurologically reprogram the bladder's stretch receptors. You tell her to hold the urine for gradually increasing intervals. And the timeline you must memorize for the AKT here is 6 weeks.
That is the exact trap the examiners will set. Stress incontinence. 3 months of physical pelvic floor exercises. Urge incontinence. 6 weeks of neurological bladder training. If the 6 weeks of bladder training fails for urge incontinence, only then do you reach for the anticholinergic medications like oxybutynin or tolterodine to chemically relax the bladder muscle.
And if the medications fail, secondary care can inject botulinum toxin directly into the bladder wall to paralyze the overactive muscle or perform complex sacral nerve stimulation.
And with that, we have reached the end of the curriculum. We have taken a massive, intimidating stack of textbook bullet points and built out the underlying clinical matrix. We've traced the logic of amenorrhea, unpacked the pharmacology of menorrhagia, navigated the complex math of the Day 21 test, understood the microbiology behind the PID triple therapy, and walked the labyrinth of the HPV screening pathway.
It is a vast amount of information. But when you understand the why behind the what, it stops being a memory test and starts being clinical intuition. As a final provocative thought, I want you to consider how much of gynecological diagnosis and management relies entirely on the precise measurement of time, a Day 21 progesterone test that actually requires you to calculate Day 28, waiting exactly 12 weeks postpartum for a smear test so the cells can remodel, a 3-month trial of pelvic floor exercises versus a 6-week trial of bladder training, diagnosing amenorrhea based on a 2-year delay between age 13 and age 15. In women's health, time is not just a passing variable. It is as vital a diagnostic tool and therapeutic intervention as any blood test, ultrasound, or prescription pad you have in your clinic.
Time, the ultimate diagnostic tool. Think back to our opening thought. Medicine isn't a static map. You are managing a dynamic, beautifully complex moving system. Understanding the timing of that system is everything. You now have the framework. We wish you the absolute best of luck on your AKT. Keep connecting those dots.